So a shoulder dystocia is more commonly defined where you have the anterior shoulder trapped behind the symphysis pubis, so it's a bony problem, or sometimes you may also have a posterior shoulder which is actually trapped behind the sacral prominence of the pelvis. So this is going to be a demonstration of the OSCE for the management of a shoulder dystocia.
Mandy, welcome to your OSCE test station. I'm going to read a scenario out to you and then I want to make sure you've understood it. So if you need to repeat it, then go ahead.
Okay.
Then you've got 10 minutes on the clock and then I want you to show me the management of that emergency.
Okay.
You've got the paper and the pens to use to make notes, and obviously we've got the equipment behind us where you can demonstrate some of the manoeuvres.
Okay.
Ready to start?
Yes, I am.
Mandy, your scenario is: Wendy is in her third pregnancy. Her first baby was delivered using Keeling's forceps and it weighed 3.5 kilograms. The second baby was born by Von Tu's extraction and weighed 3.8 kilograms. Wendy is now on the labour ward in spontaneous labour at term. She progressed quickly through the first stage of labour but is experiencing delay in the second stage. The head eventually crowns, but you have difficulty freeing the baby's chin. Finally, the head is born, but there is no further progress. Do you understand the emergency?
Yes, I do. Yes, thank you.
Ready?
Yeah, I am. Thank you. Okay, so the emergency here is a shoulder dystocia. So I'm just going to make a few notes then, first of all, what I'm going to need to do. Okay. Okay, so the first thing I'm going to need to do is to call for help. So I need my emergency buzzer and I'm going to call for my soaps. So I'm going to need to have my senior coordinating midwife because I need to inform her so that she can help coordinate the emergency. I'm going to need a senior obstetrician because I may need some help with the manoeuvres and the management of the situation. I'm going to need a senior anaesthetist. He may be able to assist with pain relief. We may also need to cannulate for sort of potential for the third stage of labour as well. I'm going to need a paediatrician because I'm going to be anticipating neonatal resuscitation. I also need to make sure that I've got a resuscitator in the room and that it is checked and switched on and ready to receive the baby. I'm also going to need some extra people, so I'll need extra midwives and whoever is available really just to help sort of manage the situation. And I will also need a scribe because it's really important that we have documentation of events as they actually happen. I need to note the time that the dystocia happens, so I need to note the time of the delivery of the head and when I've called for help. And first of all, I need to also ascertain fetal well-being. So I need to, if I can, and there's time to listen into the fetal heart so we know what the fetal heart is doing, and also consider ongoing fetal monitoring as well. So maybe get somebody to put her on a CTG if possible. I'm now going to go and demonstrate the manoeuvres that I'm going to need to do to assist delivery of the baby. Okay, so in order to do McRoberts, first of all, we need to make sure that the bed is flat. So I'd need to take any pillows away and lower the back of the bed right down, okay? Also, what I need to ensure is that mum is towards the end of the bed so that we've got room to actually access and perform any manoeuvres. So mum would need to come down to the bottom of the bed. In order to do McRoberts manoeuvre, I'm going to, myself, and I'd need probably another midwife as well, to take the legs and actually to move the legs right back. And the idea is with McRoberts manoeuvre is that you are flexing the leg at the hip and abducting the hip so that you are opening the pelvic cavity. What McRoberts actually does is flatten the sacrum, and it also then rotates the symphysis pubis anterior, in an anterior direction, so that actually widens the pelvic cavity, and in most cases that might be enough to actually free the baby. Once we've done McRoberts manoeuvre, I'm going to attempt to deliver the baby. Now, I would have already told mum to stop pushing at this point because shoulder dystocia is a bony problem, and what we don't want to do is impact the shoulders any further on the symphysis pubis. So once she's in McRoberts, I'm going to then attempt to deliver the baby, and I'm just going to use routine axial traction on this baby, because what I don't want to do is to risk any damage to the brachial plexus nerve. If I can't manoeuvre the baby with McRoberts manoeuvre, I need to move on and do the next manoeuvre. So that would then be suprapubic pressure. Keeping mum in McRoberts, I need to make sure that we know which position this baby is in, because we need to know where the back of this baby is. Okay, so I would have already palpated and know that the back of this baby is on this side. So to do suprapubic pressure, the aim is to try and push the shoulder underneath the symphysis pubis. So there's two methods of doing suprapubic pressure. First of all, I'm going to do like a sort of locked manoeuvre. So I'm going to just sort of lock my hands. I'm going to just have my heel of my hand just above the shoulder, and then just do a sustained downward action for about 30 seconds to try and in the direction of the shoulder to try and free the shoulder. Whilst I'm doing this, somebody else would attempt to deliver the baby. If that doesn't work, then I could try and do like a rocking action again for about 30 seconds with somebody then attempting to deliver the baby. If that doesn't help and doesn't free the baby, I need to then move on and do the internal manoeuvres. So the aim of suprapubic pressure is actually to reduce the diameter of the baby's shoulder so that it can pass underneath the symphysis pubis. So suprapubic pressure is actually going to then reduce that diameter of both those shoulders to allow the shoulder to pass underneath the symphysis pubis. So in order to demonstrate the internal manoeuvres then, there's two types of manoeuvres. We're either going to do internal rotational manoeuvres, or we're going to try and deliver the posterior arm. It doesn't matter which way round we do them, it's whichever is easiest with access. In order to gain access, this is where we may consider a episiotomy. So in order to access then, I'm going to sort of follow which direction the baby's back is in. I'm going to enter at the bottom, so my hand needs to be in this sort of position because we don't want to be sort of trying to manoeuvre ineffectively. So at the bottom then, I'm going to move in posteriorly, and I'm going to follow the baby's back up to the posterior aspect of the anterior shoulder. And the idea is what I'm trying to do is to rotate and push that baby's shoulder around in the direction that the shoulder is facing. So somebody at this point would still be doing suprapubic pressure. If I can, and there's room, I'm able then to enter with my other hand as well, and this time I would be entering and putting my hand at the anterior aspect of the posterior shoulder, and I would be trying to sort of push my hands against each other to rotate that baby's shoulder around. If that doesn't free the baby, then I'm going to move my hands around. So I'm going to slide this hand back. I'm going to slide it to the bottom, to the posterior aspect of the posterior shoulder, and I'm going to try and push the baby from the posterior shoulder. And again, I can use, if I've got room, my other hand to push against my two hands and to try and rotate that baby around. If that doesn't work, then I can consider freeing the posterior arm. So in order to do this, I need to again enter at the bottom. I need to be able to feel down the baby's arm to the elbow, and I need to then flex that arm. If it's not already flexed, flex it at the elbow so that I can then free and feel where the baby's wrist is. And then I'm going to just, like a cat lick manoeuvre, free that baby's arm over its face, and that then will drop the posterior shoulder and also then free the anterior shoulder, so I should be able to deliver the baby. If, however, none of these manoeuvres have worked, then what I'm going to need to do is to consider roll in mum, because we need to change maternal position. So what I would then ask mum to do is actually to roll over, if she can, into an all-fours position, and again attempt to deliver the baby. If that still doesn't work, then our next action would be to repeat all the manoeuvres again. So we'd move her back onto her back and just start at the beginning again. There are other manoeuvres that we can consider as well if we have an emergency like this, and that may be that we need to actually break the baby's clavicle, so a clidectomy, okay, which would actually sort of allow for the shoulder to be born. The other manoeuvre is that we could do a physioptomy, which would be to cut the symphysis pubis ligament, so that would separate the pelvis and free the baby. The other manoeuvre is the Zavanelli manoeuvre, which would be where we would manually displace the baby back into the uterus and then deliver by caesarean section. However, if we're doing that, we would have a baby that is in a very, very poor condition at this point. So the other considerations that I have then, so I need to consider maternal considerations, okay, so this is obviously a very traumatic event for mum, so we would need to consider her psychological state really, so she would need certainly debriefing afterwards and a duty of candour. She's also at risk of a PPH, so we would need to have an active management of the third stage of labour. We also need to determine any perineal trauma, so she could have an episiotomy, but there could be some other substantial trauma that we'd need to identify and suture. For the baby, we need to consider any birth injuries. So again, there could be a brachial plexus injury to the baby. So it's very important that we have a thorough ped check afterwards and that we identify which shoulder was checked. Other considerations we need to make really is sort of health and safety. So we need to make sure our room is safe, that we haven't got lots of equipment everywhere because there's going to be a lot of people in the room. There could be spillages of blood on the floor as well. We need to consider ethical considerations. So there's going to be a lot of people in the room, traumatic situations. So we need to think about mother's sort of safety, dignity, and also the effect that maybe this baby could have a poor outcome. We also need to have a effective chain of command, so we need good communication with the clients and also the multidisciplinary team. We need to make sure that the midwife in charge, the coordinator, is fully informed of the events. We also need thorough record keeping, and the other issues are consent as well. So if we need to do the internal manoeuvres, and the other consideration would be pain relief as well. Okay. So just the final considerations I need to think about would be consent issues. So obviously we're going to need to do some internal manoeuvres. We may need an episiotomy, so I'd need to gain consent from mum about that. We'd need to consider record keeping as well. So we'd need to make sure that everything is documented thoroughly in the notes as soon as the event as possible. The other considerations may be that I would need to do a datex form, an incident form, and also consider support for the midwives or anybody involved in the incident. So I may want to talk to either the supervisor of midwives or the professional midwifery advocate for support. So you haven't prompted me at this point, so I would assume that I have mentioned everything that I've needed to. So I'm just going to think now if I need to mention anything else.
Thank you, Mandy. That concludes your OSCE test station.
Thank you.